Ultimate Guide Module 4 Understanding Insurance. Learning Objectives: to demonstrate an understanding of the wide range of payer types encountered in a hospital, clinic, or office setting, including major types of healthcare plans, HMOs, PPOs, POSs, and commercial plans, types of Medicare plans, types of Medicaid plans, workers' compensation, auto insurance, liability coverage, commercial insurance, TRICARE and CHAMP VA, guidelines for determining guarantors and subscribers. Module 4, a self-assessment question. Question number 1. The ABN is defined as Option A, American Beneficiary Network, Option B, Access Benefits and Notices, Option C, Alternate Benefits Notation, Option D, Advanced Beneficiary Notice. Question 2. Medicaid provides health care for certain low-income people through a jointly funded and administered program through a state-federal partnership, B, local-federal partnership, C, local-state partnership, D, regional-federal partnership. Question number 3. With workers' compensation, the blank must authorize the use of workers' compensation services. Option A, insurance carrier. Option B, OSHA. Option C, employer. Option D, federal government. Question number 4. Medicare is Option A federal health insurance program for people age 65 and older, people of any age with end-stage renal disease, and certain disabled people under age 65. Option B, Medicare Part A covers a portion of inpatient hospital services. Medicare Part B covers a portion of doctor's services. Option C, Medicare is managed by Centers for Medicare and Medicaid Services. And Option D, all of the above. Question number 5. Under the Medicare Prospective Payment System, PPS, a hospital can change and bill all of the following to a Medicare beneficiary except Option A, applicable coinsurance and deductible amounts, Option B, private room deferral, Option C, outliner days not approved by peer review organization, Option D, television, telephone, and personal comfort items. Question number 6. The following is true of Medicare lifetime reserve days. Option A provides an additional 60 days of inpatient coverage. Option B can be used for one time for skilled nursing care. Option C is a renewal for a different occurrence at least 1 year apart. Option D is a once-in-a-lifetime extension on inpatient care. Question number 7. Under Medicaid, hospitals that cover for unusually large portion of low-income patients may receive additional payments from the state. This is termed Option A, disproportionate share, B, federal insurance contribution share, Option C, capitation fund, Option D, coordination of benefits. Question number 8. All of the following are Medicare Part B services except Option A, services paid by voluntary premium payments, Option B, outpatient services, Option C, services rendered by a physician, Option D, inpatient services rendered by a hospital. Types of healthcare coverage. Understanding various types of healthcare coverage. It is sometimes assumed that because a patient is insured, all healthcare costs will be covered. However, coverage levels can vary greatly depending upon the type of healthcare plans a patient has. Features and options widely vary among types of plans, more so than among companies or organizations providing the plans. What varies the most amongst companies is usually cost. Some companies' rates are more than others. Understanding various types of healthcare coverage, many people receive health insurance through their employers. However, it is important to note that some employers may pay more for healthcare costs than others. It is important for patient access services personnel to know that many people may not understand much about the type of coverage that they have. There are HMO, EPO, point of service, and PPO plans. The grid below shows the different indicators that makes each of these health insurance coverages different from one another. That could be whether they need a PCP, if that's required, if it's out-of-network coverage, are there referrals to see a specialist, and of course the cost. Access management staff often play an important role in educating patients about types and levels of coverage. We can better serve our patients by increasing our own understanding of the differences among the healthcare plan types. HMO, Health Maintenance Organization. Insurance plans that strive to control healthcare costs by requiring members to receive services at designated facilities and by promoting wellness by regular physician checkups. All services except those providing in life-threatening situations must be provided or approved by a participating physician. Typically, members must select a primary care physician or PCP affiliated with the HMO, who is responsible for that oversight of the patient's entire healthcare continuum. The PCP must approve any non-urgent services. A health maintenance organization works like a club for both the patients and the healthcare providers. Subscribers to an HMO receive medical services from participating physicians, clinics, and hospitals. An insurance company sets up an HMO and gets a group of doctors to participate. The insurance company and the doctors agree on certain costs and charges, which lets the insurance company control the expenses and provide lower prices. Patients choose primary care physician, a PCP, from a list of participating doctors. The PCP becomes the personal physician who the patient sees for routine medical care, like annual exams and health issues. If the patient needs to see a specialist, or be hospitalized, or have a lab or x-ray work, the patient must obtain authorization from their PCP in order for those services to be covered by the HMO. HMO features. Patients may have to pay some portion of the cost, called a copayment, or copay for short, for each office, hospital visit, such as a $20 per doctor visit or a $200 copay for emergency room visits, regardless of what services are rendered. Patients may also have to pay extra for some services, emergency room, mental health, chemical dependency services, for example. Patients do not have to fill out claim forms, which makes this relatively simple system. PPO, Preferred Provider Organization. PPOs are contracts between employers, doctors, and hospitals. The doctors and the hospitals agree to provide their services at a discount in return for a volume of patients who are PPO members. Preferred Provider Organization, PPO. Members are not required to select primary care physician, but they must use one of the group's doctors in the hospital to obtain full coverage. If a member chooses to go to a non-participating provider or facility, their coverage decreases and they may have to pay more out of pocket. PPOs offer more choices and access than HMOs, but there is a typical cost associated with that freedom that is higher than an HMO cost. Like an HMO, a PPO is a network, but rather than choosing a primary care physician, the patients can see any health care professional in the network anytime they choose and make an appointment. PPO patients don't need referrals for specialists or other services. They can even see professionals outside of the established PPO network. However, we can better serve our patients if we inform them prior to the visit or the encounter if they choose to do so, if their portion of their cost will be higher. PPO overview. PPO features. Patients have choices to make about their insurance options within the PPO system when they enroll. Their choices will apply to themselves and their dependents they enrolled in the plan and can usually only be changed once a year during open enrollment periods. Patients receive a list of participating medical professionals which they can choose to find for their healthcare needs, or they may continue to see any provider they already use. Patients may have to pay a portion of the cost for each office or hospital visit, regardless of how much the visit costs. This payment is called a copayment. Patients may have to pay extra for some services, emergency room, mental health, and chemical dependency services, for example. Generally, PPO cards have the following information: an ID number, member number, social security number, employee number, or plan number. Typically nowadays, with protecting health information, social security number information is usually not reflected on the cards. An effective date should definitely be shown on the card, and copayment amounts such as ER and clinic visits and specialties and office visits will be listed. Point of service plans. POS plans combine characteristics of HMOs and PPOs. Patients choose a primary care physician who controls all the aspects of the care, including referrals to specialists. All care received under the physician's guidance, including referrals, is fully covered. Care received by out-of-plan or out-of-network providers is reimbursed, but the patient then may have to pay a significant copayment or deductible. POS patients decide each time they need medical care whether they want to use their plan as an HMO or a PPO. As in the case with PPOs, we can better serve our patients if we inform them prior to the visit or encounter that their portion of their costs will be higher if they choose to use the PPO option. HMO, in-network only, primary care physician, usually needing a referral to go to a specialist, and then they usually have cheap premiums. PPOs, or out-of-network, no primary care physician is needed, or specialist, no referrals, and the cost of the premiums are higher. Commercial insurance overview. Insurance that is not Medicare, Medicaid, federal, state, or county programs, workers' compensation, Blue Cross Blue Shield, automobile insurance, PPO, HMO, is considered a commercial insurance. Typically, commercial insurance companies do not require a specific contract with a provider organization to reimburse for the patients. Patients with commercial insurance are not required to select any primary care physician or go to any specific provider. Also called traditional indemnity or major medical coverage, commercial insurance is the least restrictive option of all three main plan types. Commercial insurance allows patients to see any licensed healthcare professional for anything covered underneath their insurance plan. Patients choose deductibles and any other options when they enroll, and those also apply to the patient and the dependents as they've enrolled in the plan. Commercial insurance features. Deductibles apply to each person enrolled in the plan. For example, if a patient and a spouse enroll and select a $500 deductible, each must pay $500 in medical expenses before the plan starts paying further costs each year. Costs that exceed the patient's deductible are covered by the co-insurance plan, so the patient and the insurance company share the cost of the services covered by the policy. For example, with an 80-20 plan provision, the insurance company pays 80% and the patient pays 20%. Commercial insurance features. After the patient pays his or her deductible, co-insurance maximums called stop-loss provisions apply that protect the patient from skyrocketing bills. Patients may have to pay extra for some services such as emergency room, mental health, and chemical dependency services. The cards for commercial insurance vary from carrier to carrier. Generally, commercial cards will have the following information: an ID number, a plan number, policy number, an employee number or insured number, and a group number. The policyholder's Social Security number is required for billing purposes. Health plan types at a glance. HMOs offer lower cost of care and simplicity and ease of payment through simple paperwork. PPO plans offer flexibility and choices for the patient, along with that simply easy lack of paperwork process. Commercial offers flexibility and many choices for the patient. Workers' compensation. Services that are a result of work-related accident or injuries are paid for either by the patient's employer or by the employer's workers' compensation insurance company. The employer must authorize the workers' compensation services. If there is no authorization, you should attempt to contact the employer for authorization. For billing, a claim number or the name of the person authorizing the service is required. The patient's Social Security number is also required for billing. There is no card provided for workers' compensation. Obtain the name of the workers' compensation carrier, the claim number, the billing address, the adjuster's name, the telephone number for the adjuster, if possible at the time of registration. Or provide the patient with information so that they can return a phone call or send this information via email, so it can be added to the registration at a later time. Auto insurance. Auto insurance is often the primary insurance for injuries that are a result of an automobile accident. Rules regarding the primary between auto and health insurance are determined by state regulations and may vary from state to state. Guidelines for auto insurance are as follows. If a patient has no health insurance, then the auto insurance would be primary. If a patient has Medicare or Medicaid as their primary insurance and the services are a result of an auto accident, the auto accident insurance would be primary. Obtain the name of the automobile insurance carrier, the claim number, the billing address, and the adjuster's name and phone number if possible at the time of registration. For injuries that are a result of negligence of another party, generally our hospital have their own policies regarding billing for personal liability cases. Registration staff should follow the policies of their hospital. For Medicare patients, liability should be identified as a result of Medicare Secondary Payer Questionnaire. Regulations require that liability insurance be billed prior to billing Medicare. If the liability company issues a denial, Medicare will pay on the condition that the liability is not established in the future. TRICARE and CHAMP VA. TRICARE is a health care program overseen by the Department of Defense in cooperation with general civilian contractors. TRICARE provides 4 options to eligible beneficiaries. TRICARE Prime, similar to an HMO, active duty service members are automatically enrolled in TRICARE Prime. TRICARE Extra, preferred provider option that saves money for the patients. TRICARE Standard, a fee-for-service option, which is the same as the former Champus US, the Civilian Health and Medical Program of Uniformed Services. TRICARE for Life, provider expanded medical coverage for Medicare-eligible beneficiaries. CHAMP VA, the Civilian Health and Medical Program for the Veterans Administration, is a health benefit program for the families of veterans with 100% service connected to disability and a surviving spouse or children of a veteran who dies from a service-connected disability. The Department of Veterans Affairs determines eligibility and processes CHAMP VA claims. Medicare. Medicare is a federal insurance program for people age 65 and older, people of any age with end-stage renal disease, and certain disabled people under the age of 65. Medicare is managed by the Centers for Medicare and Medicaid Services, which is a part of the Department of Health and Human Services. Although most features of the Medicare program are universally applied, there is some variation from state to state for Medigap programs in the managed care offerings. There are also variations in the way some billing rules are interpreted from one fiscal intermediary carrier to another. The original fee-for-service. This is available everywhere in the United States. While Medicare beneficiaries are automatically enrolled in this plan, other health Medicare plan choices are available. The standard Medicare plan has two components. Medicare Part A covers a portion of inpatient hospital services, skilled nursing facility services, home health services, and hospice care. Medicare Part A helps pay for up to 90 days of inpatient hospital care in each benefit period. Covered services include semi-private rooms and meals, general nursing services, operating and recovery room costs, intensive care, drugs, laboratory tests, x-rays, and all other necessary medical services and supplies. Medicare Part B covers a portion of doctor's services, outpatient hospital services, medical equipment and supplies, and other health services and supplies. Part B is optional, with the beneficiaries paying a separate fee for this. The premium is deducted from the beneficiary's Social Security, Railroad Retirement, or Civil Service Retirement check. Medicare Advantage, also known as Medicare Part C. Part of the Balanced Budget Act of 1997 that permits Medicare recipients to select coverage amongst various private health care plans that include HMOs, PPOs, point-of-service plans, medical savings accounts, fee-for-service plans, and provider-sponsored plans. These plans will receive a per capita payment per enrollee from the federal government, and the plans have the option to charge the enrollees a monthly premium. Medicare Advantage, Part C continued. Persons who are eligible for Medicare Part A and are enrolled in Medicare Part B are eligible for enrollment in either the traditional Medicare program or Medicare Part C program. Each November, the Healthcare Financing Administration will conduct an open enrollment period so that persons may select the type of healthcare program which they wish to participate in. Persons who are eligible for Medicare Part A and enrolled in Medicare Part B are eligible for enrollment in either traditional Medicare program or Medicare Part C program. Each November, the Healthcare Financing Administration will conduct an open enrollment period so that persons may select the type of healthcare program in which they wish to participate. Medicare managed care plans may include health maintenance organizations, HMOs, with a point-of-service option, provider-sponsored organizations, and preferred provider organizations. These types of plans involve a specific group of doctors, hospitals, and other healthcare practitioners who provide care to members of the plan. Medicare managed care plans provide all services covered by both Part A and Part B. Most offer a variety of additional benefits like preventative care, prescription drugs, dental care, hearing aids, eyeglasses, and other items not covered by the original Medicare plan. Costs for these extra benefits may vary amongst plans. Medicare private fee-for-service plans. The private insurer, rather than Medicare program, decides how much it pays and how much the beneficiary pays for a particular service. The beneficiary may go to any doctor or hospital that accepts the items of the plan's payment. Medicare drug coverage plans helps cover the cost of prescription drugs, may lower costs, and protect against higher out-of-pocket costs for the beneficiary. There are two ways to get Medicare drug coverage. Medicare drug plans. These plans add drug coverage to the original Medicare, some Medicare cost plans, some private fee-for-service plans, and medical savings account plans. The beneficiary must have Part A hospital insurance and/or Medicare Part B medical insurance to join a separate Medicare drug plan. Option 2, Medicare Advantage Plan, Part C, or other Medicare health plan with drug coverage, Part A, Part B, and drug coverage through these plans. Remember, beneficiaries must have Part A and Part B to join a Medicare Advantage plan. Not all plans offer drug coverage. To join a Medicare drug plan, Medicare Advantage plan, or other Medicare health plan with drug coverage, you must be a United States citizen or lawfully present in the United States. In addition to the original Medicare plan and Medicare managed care plans, other Medicare health plan choices may be available in a given area. These include private fee-for-service plans, Medicare Medical Savings Account MSAs plans, and religious fraternal benefits plans. 2-Midnight Rule. CMS adopted the 2-Midnight Rule for admissions beginning on or after October 1st of 2013. This rule established Medicare payment policy regarding the benchmark criteria to use when determining whether an inpatient admission is reasonable and necessary for purposes of payment under Medicare Part A. In general, the 2-Midnight Rule states that inpatient admissions would be payable under Part A if the admitting practitioner accepted the patient to require a hospital stay that crossed 2 midnights and the medical record supports that reasonable exception. Medicare Part A payment was generally not appropriate for the hospital stays accepted to last at least more than 2 midnights. Cases involving in a procedure identified in the inpatient-only list or was identified as rare and unusual exception to the 2-Midnight Rule benchmark by CMS were exceptions to this rule and were generally deemed to be appropriate for a Medicare Part A payment. Pre-admission diagnostic service. Medicare's 3-day, also known as 72-hour rule, requires that the pre-admission testing and diagnostic services provided to a beneficiary by the admitting hospital within 3 days before the admission are to be included in the inpatient payment. They are not to be billed as a separate outpatient charge unless there is no Part A coverage. This provision does not apply to ambulance services. Benefit periods. The number of days that a Medicare covers the care for hospitals and skilled nursing facilities is measured in benefit periods. A benefit period begins on the first day of services as a patient in a hospital or skilled nursing facility and ends 60 days after discharge from the hospital or skilled nursing facility, provided that the 60 days has not been interrupted by skilled care in any other facility. There is no limit to the number of benefit periods. The beneficiary must pay the inpatient hospital deductible for each benefit period. Lifetime reserve days. Medicare will pay for an additional 60 days of hospitalization when a beneficiary is an inpatient in a hospital for greater than 90 days. The 60 days can be used only once in a lifetime. For each lifetime reserve day, Medicare pays all covered charges except for the daily coinsurance. Carriers and fiscal intermediaries. Private insurance organizations called Medicare carriers and fiscal intermediaries handle claims and interpret reimbursement regulations under the original Medicare plan. Carriers handle medical insurance, Part B claims. Fiscal intermediaries handle all the hospital insurance, Part A claims. The Social Security Administration does not handle claims for Medicare payments. Important message from Medicare. The Important Message from Medicare, or IMM, is given to all Medicare beneficiaries who are inpatient in participating hospitals. It explains their rights as a hospital patient, including the right to all the hospital care that they need and to follow-up care after discharge. It also advises beneficiaries about what to do if they feel that they are being discharged too soon and provides the phone numbers for the PRO or peer review organization. Beneficiaries may remain in the hospital without being charged while the case is being reviewed. Hospitals cannot force beneficiaries to leave while their case is being reviewed. Advanced Beneficiary Notice, ABN. The Advanced Beneficiary Notice is a document explaining to beneficiaries that the test or the procedure ordered by the physician does not meet the requirements for being medically necessary by the Medicare guidelines based on the physician's documentation and diagnosis. Since it is unlikely that the Medicare will be reimbursed for that test, the patient may be financially responsible for the bill. If an ABN has not been signed before the service is rendered and Medicare does not pay for the test, the patient cannot be held responsible for paying for that service. If the ABN was signed, the patient may be billed for the services. An ABN only applies to the original Medicare plan. It does not apply to Medicare managed care plans. For additional details and more information, look at the information on Course 8 under Regulatory Compliance. CMS requires that ABNs contain the following information: listing of the test or tests that are not covered, the fact that the physician or the laboratory believes that Medicare is likely to deny payment for a specified test, the reasons that the denial is likely, a statement that the patient will be responsible if Medicare denies payment, a space for the patient to sign indicating his or her agreement to pay for the test if Medicare does not. Some people who have Medicare have other insurance, not including Medigap policies, that must pay before Medicare pays its share of the bill based upon the diagnosis. Medicare is secondary to the following payers: employer group health plans with greater than 20 employees for patients over 65 who are insured by either their own or their spouse's employer, and no-fault insurance. For more information and details, look at Module 7, Regulatory Compliance. Medicare Secondary Payer. Automobile medical insurance, liability insurance, workers' compensation, black lung, disabled patients under 65 who are covered by group health plan insurance with more than 100 employees, veterans affair liabilities. These are a listing of possible insurance coverage that would become primary and Medicare would then be secondary. Patients who have Medicare because of permanent kidney failure. If a beneficiary is eligible for Medicare solely based on end-stage renal disease, ESRD, the employer group health plan is primary carrier for 30 months coordination period. Medicare is the secondary payer and may pay for the remaining costs if the employer group plan does not cover 100% of the beneficiary's healthcare bill. For additional information, look at the Regulatory Compliance module. Medicare Supplemental Insurance. There are several types of private health insurance that pays some or all of the healthcare costs that is not covered by Medicare. Supplemental coverage includes employee coverage from the employer or the union, retiree coverage from a former employer or union, Medigap coverage from a private company or group. Medigap Insurance. Medicare Supplemental Insurance, which is Medigap, is a private insurance that is designed to help pay Medicare cost-sharing amounts, such as Medicare's coinsurance and deductibles, and uncovered services. Medigap insurance must follow federal and state laws. Medicare Select, a type of Medicare supplement health insurance similar to Medigap. The only difference between Medicare Select and the standard Medigap insurance is that each insurer has specific hospitals and specific doctors that participate they must use except in emergency care in order to be eligible for their full benefits. Medicare Select policies generally have lower premiums than other Medigap policies because of this requirement. Medicaid. Medicaid was established by the federal legislation in 1965 to provide health care for certain low-income people. It is funded and administered through state and federal partnership. Federal law mandates coverage of basic health care services for categories of low-income people. States have a wide degree of flexibility to design their program. States have the authority to establish eligibility standards. They have the option of covering other needy people, determining what benefits and services to cover. They have the option to provide medical services not mandated by federal law, and they can set the rates. Qualifications for Medicaid. People eligible for Medicaid include certain low-income families with children, aged, blind, or disabled people on supplemental security income, certain low-income pregnant women and children, certain persons who would not otherwise be eligible but may qualify as a result of catastrophic medical expenses. Because states have the flexibility in structuring their Medicaid programs, there are variations from state to state. All states, however, must cover the following basic services: inpatient and outpatient hospital services, laboratory and x-ray services, skilled nursing and home health services, and doctor's visits. Family planning, periodic health checkups, diagnostic and treatment of children. Traditional Medicaid. After a person is financially eligible for Medicaid coverage, their financial status is evaluated on a regular basis. The patient's current eligibility status is usually verified via telephone or online at the time of registration, or perhaps during scheduling or pre-registration. Some states will issue new Medicaid cards on a monthly basis. HMO Medicaid. Details of Medicaid contracts with HMOs are determined by the individual states. Healthcare organizations contract with the HMO to provide services to Medicaid recipients. Requirements for billing may vary based upon the contract of your organization and the HMO. In general, the contract is arranged so that those claims are submitted directly to and paid by the HMO, which is then reimbursed by Medicaid. Guidelines for determining guarantors. The guarantor for an account is the responsible party for payment of the services that may not be covered by a third-party insurance. A guarantor accepts responsibility for any balances that insurance won't pay. A common registration mistake involves assuming that the insurance subscriber is automatically the account guarantor. Patient access staff must ask the following questions to establish the guarantor. Who will be responsible for the balances that the insurances won't pay, or who will be responsible for the bill? To determine the account guarantor, use the following guidelines. Adults, patients who are 18 years of age or above, adults will be considered the guarantor of their own accounts unless a spouse or other party signs a consent form accepting responsibility for the patient's bill. Children, patients who are younger than 18 years of age, both parents are equally financially responsible for the care received by their minor children. This responsibility can only be arbitrated via court order. The patient who brings in the child for care is generally considered the guarantor for the account. Guidelines for determining the primary insurance for dependent children. The birthday rule. The birthday rule is an informal procedure used in healthcare insurance industry to help determine which health plan is considered primary. When children are listed as dependents on multiple healthcare plans. This scenario occurs often amongst divorced parents. Parents include their children on each other's insurance plan to maximize coverage and to ensure that the child will be covered when visiting the other parent. Please note that these guidelines are common amongst insurance companies, but they are not governed by law. Practices may vary from one insurer to the other. The insurance plans need to coordinate benefits so that the claim is properly paid. To prevent overpayment, one parent's plan is designated to be primary plan and the other is listed as a secondary plan. The birthday rule determines which plan is primary. It states that the health plan of the parent whose birthday comes first in the calendar year will be considered the primary plan. As a special note to only focus on the month and the date of the parent's birth date, not the year. Excluding their birth year, it is not about which parent was born first chronologically, just the date and the month in which the parent was born and who is first when looking at the calendar in that order of month and date of birth. Birthday rule exceptions. Exceptions to the birthday rule include parents that share the same birthday, divorced or separated parents, active employees, and different plan types. Parents that share the same birth date. When parents have the same birth date, the parent who had their plan longer is primary. Parents that are divorced or separated. When the parents are either divorced or separated, the plan of the parent who has legal custody will be considered primary. If the parent with custody is remarried, the new spouse's plan would then be considered secondary. The plan of the parent without custody would pay any additional expenses not covered. Parents that are considered divorced or separated, you also need to consider the non-custodial parent's plan would provide a third layer of insurance protection. This order of payment can be altered by the court-issued divorce decree or by agreement, but the insurance companies need to be notified. Active employees. If one spouse is currently employed and has insurance and the other spouse has coverage through a former employer through COBRA, the plan of the currently employed or active spouse would be primary. Guidelines for determining policyholders, the subscribers. The policyholder or subscriber is the person who contracts with the insurance company for healthcare coverage. The policyholder may or may not be the person whose name appears on the card. To determine the policyholder, use the following guidelines. For most Blue Cross commercial and PPO preferred provider organization insurance, the policyholder is the person whose name appears on the insurance card. Most HMO health maintenance organizations give each insured person his or her own card. In this instance, the person on the card may be the patient, but the patient may not be the policyholder. You will need to ask who the policyholder is on the insurance. For most HMOs, the policyholder can be identified by the two-digit suffix or ending of the policy ID. It's usually 01 for the spouse, or usually identified by suffixes of 2, 1 for the patient or the policyholder, 2 for the spouse, 3, 4, and so on for the dependents. For TRICARE, formerly known as Trampus, CHAMP-VA insurance policyholder will be the sponsor or the person who is active or retired from the military. For Medicare, Medicaid, workers' compensation, the policyholder will always be the patient. Always obtain the name, date of birth, and social security number and other demographics for the actual policyholder. Managed care. What are carve-outs? A carve-out is a managed care lingo for a program that separates certain types of services or patient groups, most commonly in the area of mental health and substance abuse, collectively known as behavioral health care, and provides them separately, usually through a separate managed care behavioral health contract. or a MBHC. Access management impact. Behavioral health care, mental health, substance abuse carve-outs are estimated to cover 30% of the employer-based non-HMO plan to 60% of all insured persons. As a carve-out billing is usually managed by companies other than the patient's original payer, it is easy to negatively impact payment by incorrectly billing the wrong insurance company. In fact, the most common reason for carve-out denials is failure of access management staff to notify the correct carve-out company for behavioral health admissions in a timely manner when claims are incorrectly forwarded to the original insurance company. In such situations, carve-out companies may require notification of admission within 24 hours or 1 business day. During that time, it is required to incorrectly bill the original plan and receive a non-covered service denial. Precious time is lost in notifying the carve-out company. Access management personnel who are not trained to recognize the increased incidence of MCBH carve-out placed in their hospitals are a great risk. For more information and detail, look at Course 5, Managed Care. Now here is the answers to the self-assessment